Hello, and welcome to Navigating Nursing. I am your host, Laura Whitehead, a registered adult nurse, a critical care nurse, qualified lecturer, and fellow of the Higher Education Academy. I would like to welcome James Pyke, who is a clinical site practitioner at Croydon University Hospital. Welcome, and thank you so much for joining me today, James.
Thank you.
Back to where you studied, we met at King's College London. You've guessed by now I'm basically making everyone that I know come on a podcast. So welcome, thanks so much. Why did you choose nursing and why did you pick King's College London University to go to?
For me, King's had a very good reputation. The opportunities to study at some incredible hospitals, a lot, an incredible university was what swung it for me.
To be honest, it was working at Guy's and St Thomas's that was the driver for me to actually apply. The fact that King's is obviously very good.
There's always faults, I think, with any university you go to, but I can look back very comfortably and say training at Guy's and St Thomas's has really set me up very nicely.
Completely. Yeah, I completely agree. I'd make the same
and
decision.
as King's, to be fair, I'd always go to King's again if I had the opportunity.
Keep going back there. I think they're a bit fed up.
So to answer the first bit of the question, why nursing? I think that's a much harder question. My year group at school was very successful, with about 10%, 100 or so going on to study medicine.
Wow,
There was definitely a healthcare buzz. A levels led in, I did biology, chemistry, psychology, so we're quite suited to healthcare as well.
And then that's quite rare, I think, actually. Nurses doing, a lot of nurses I've spoken to, and I did English, history and psychology, so nothing related to science or anything. So you were completely ready for our anatomy and physiology lectures at uni.
Totally. And also work experience, I think, is vital. I had a very interesting experience with a consultant surgeon, did a week in theatres, ward rounds, that kind of stuff. And he was just nasty. And, looking back now, I'm happy I made the right choice. I think there are lots and lots of challenges with nursing. I think there are probably just as many, if not more, with medicine, particularly for, I say in inverted commas, junior doctors. They're very experienced doctors who are, middle-aged, and depending on who you're working with, I think you could be treated almost like a child sometimes.
I think nursing's has changed. We've made quite a lot of progress, haven't we, in terms of hierarchy, your opinion being heard and your opinion being valid, regardless of kind of how old you are, how long you've been. If you feel uncomfortable in a situation or you feel like a patient's deteriorating, no one's listening. I've been fortunate. I've never been in a situation where I've been ignored because I happen to be, because I look young or any lack of experience. Actually, you're right. I think in medicine, maybe that hierarchy is really reinforced still, and it still really exists.
Yes, and I think particularly, like you, I've got a critical care background. Historically, there's been a lot of work to flatten the hierarchy because we know it improves safety, it improves patient outcomes.
So your work experience put you off, and I did a week. Yeah, back. My mum's friend Charlie got me he worked at the Evelina. And he got me a week work experience, and it made me terrified of teeny babies that were poorly. And I remember walking in and being like, nope, can't do it. They're too small. And they were taking blood from like a 1-month-old baby. And I was like, I knew I just couldn't be a children's nurse. Yeah. But I really felt like I belonged. It was a really weird feeling. I kind of walked in and was like, yep, this is for me. And that was what I based my whole, kind of UCAS and my university applications. And I remember a week before I started at King's, I was like, I've made a whole life decision about university based on a week's work experience when I was 16. What if I've completely made the wrong decision? But I hadn't, luckily, so that's good.
Yeah, it's challenging, and I think benefited as well from, got some amazing work experience.
So before you went to work in intensive care, you did a year on Howard Ward, which if you haven't worked at St Thomas's, it's a mixture of private and NHS medical/elective surgery unit. Was it a conscious decision for you to go into a ward before you went to the intensive care?
Yes. So I was won over to intensive care, had a fantastic placement with guys, and I loved it. I was very heart set. This is where I want to go. But all the advice I got at the time was, you need to have a year on the wards, get that under your belt, and then apply for ICU. And it was always the first thing on the job application. You must have a year's post-qualification experience. I ended up on Howard Ward. I think that's a really good thing. Nowadays, I think it's easier to get into critical care, ED, places like that with no ward experience. Personally, I found the nurses I worked with in critical care who had no experience as a qualified nurse struggled.
I think it's very stressful, isn't it? I look back and I went to a high dependency unit, but I went between that and a cardiac ward. I did, I think, 9 months in total on one, and then moved over to the ward. And I found having that ward experience, then when I went to A&E and when I went to intensive care, I found I had the confidence because I dealt with even just the discharges and social services and district nurse referrals and kind of all of that side of it. I had the confidence to know as well that I could manage 8 to 10 plus patients on my own. That made me feel a lot more confident.
It's so important. I still remember doing that first drugs round on my own with no one watching. And you're like, paracetamol, yes, this is definitely paracetamol.
And someone swapped it once I put it in the pot.
Exactly. Let's just quickly check the BNF. Get paracetamol. Yes, no. That it's really stressful, and just getting. I think, like you were saying about the discharge processes, it's just learning all the bits and bobs that you might not have come across as a student.
And one thing I would say for any students that are listening, whatever placement you're on, whether that be your final placement in your third year, really get involved in the processes. So the discharge planning, the TTOs, the dosset boxes, the social services. I think it's quite sometimes easy as a student to miss out on learning those of these because sometimes it's just very busy and the nurse that you're working with just wants it done. And if they've done it before, it can just be a lot quicker for them to, I'll quickly just ring the warfarin clinic to get the anticoag clinic to get them booked in for their warfarin check, where actually by you doing that as the student nurse, that then gives you the confidence and the competence to do that when you qualify. So really seek out those opportunities. Obviously it's learning those clinical skills and your essential skill clusters, but it's also about kind of the administration and the organisation and the liaising with different services. That's we have to be able to do that as nurses. So after you worked as intensive care for 5 years and then you moved on to the private sector, what made you move over to the private sector?
Life happened, really. So I finished my intensive care course at St Thomas's, and my wife and I, who at the time was also a nurse at critical care at Tommy's, we had our son.
The nursing power couple.
And one of the things we were looking at is, well, how do we manage having a baby and working? At the time, we decided that both of us staying in ICU wasn't really manageable for various reasons, not least the sort of work-life balance. I just got an offer for a band 6 post in the private sector, and to be honest, it was kind of the money that won me over. It was. I remember when I told my band 7 that I was leaving, she was like, "Oh, you'll be earning more than me." I was like, "Okay, fine, I'm gone. Bye."
Yeah, bye.
For the last couple of years, it's really been a focus on providing for the family, having a bit of a break. Working in St Thomas's ICU, it's the most incredible place. I've never heard anyone say a bad word about it, but it's tiring work. ICU is very tiring, very stressful physically and emotionally and mentally. So I really enjoyed actually having a couple of years of different challenges in the private sector.
And what were the different roles that you did? So I know that you did outreach whilst you were in the private sector. How did you notice any really big differences between the NHS and the private sector of now you've worked in both?
So there are big discrepancies in the private sector. So to put it into perspective, obviously I've worked in St Thomas's, a really fantastic NHS Foundation trust. I'm now at Croydon, which is, a rapidly improving NHS trust. However, there are core things that are the same. We have ICU, you have resus teams, you have the same setup. Whichever NHS trust you're in, you have the same setup. It might have a different name for a different role.
Because we love an acronym.
Exactly. but the setup is there. I'm an SMP at Tommy's. I'm a CSP at Croydon. In the private sector, though, different hospitals can have very different setups. There's much less clinical governance across the entire private sector. Individual hospitals govern themselves. So in one hospital, I'm deliberately not going to mention names. In one hospital, very big American organisation, they were banned from having students because it wasn't safe. In another hospital, a much better one, a large independent hospital, they'd essentially tried to copy the NHS setup. We had our daily resus team meetings. ICU was very much there to support the wards. First private hospital in the country to have 24/7 outreach, and that's really, really important. Obviously, now I'm very aware that the acuity of patients in the private sector is generally much lower. The nurse to patient ratio is much higher, which is fantastic. It's different. It is very different in the private sector, and certainly if you ever get the opportunity to work there and you think, actually, you know what, now's the right time to leave the NHS for me, I would recommend it. You will gain. I've certainly gained lots, and I have absolutely no question that I wouldn't be where I am now in what is now my Band 7 role if it weren't for that sort of leap of faith, as it were, into the private sector.
And into a complete unknown. And thank you for explaining it in more detail, because I think a lot of nurses, me included, wouldn't know what the private sector's like, how different it is. You kind of might lump all private hospitals together as one without knowing that there is a massive difference between them.
Yeah, I think from conversations I've had with people, quite a few people said, "Oh, I'm not going to work in the private sector because they're all snooty and snobbish." And it's like, well, actually, no, that's the polar opposite. I've had Arab princesses hold my hand and ask me to stay and look at them for a bit longer. I've had royalty from other countries, insist I call them by their first name. It's not like that at all.
You've done your intensive care course, you've done your mentorship, and you've done your ALS, so your advanced life support. How did you find going on advanced life support as a nurse?
I loved it. So advanced life support was day one in my new job in the private sector.
Just a bit stressful then.
It was interesting, and there were a couple of us there from the same hospital, all nurses. And actually, when you're there, you're no different to anyone else. It wasn't like we're cohorted as nurses. The way it's run is you're sort of in little groups for all the simulations that you do. So one of the guys in our group, I think it was his third or fourth ALS, he was an ED reg.
Wow, so yeah,
he's pretty good, and so he wanted to be an instructor, so he was showing off all his teaching, and which was fantastic. A lot of doctors there, F1s, F2s.
Because the main difference between us and doctors is, that they have to do, junior doctors as F1s do that as part of their induction and kind of getting in their new role as a qualified doctor, where I had been a nurse for 5 years before I did my ALS. Yeah, I think about 5 years. So we're a lot more, by that point, you've obviously got a lot more experience, you've done a few roles, you're really comfortable within your role as a qualified registered member of staff, aren't you?
Yeah, I think.
But I think ALS was actually one of my most favourite courses that I've done out of everything.
Fantastic 2 days.
So really fantastic. So I'd really say to anyone listening, if that's something that opportunity is offered to you within your place of work, within your trust, please do sign up and please do go. So you recently started a new role as a clinical site practitioner. Can you outline what your role actually is? What do you do?
I'm still very much learning. It's joining the NHS as sort of a site manager during COVID has been a real baptism of fire.
Quite literally a baptism of fire.
Yeah, everything's on fire.
And you're stood in the middle with a fire extinguisher.
Yeah. So during days, there are 2 of us on shift. Myself and a more senior colleague, and they're generally in charge of bed management. They're trying to map patients through from A&E to the wards, which with coronavirus has been so much harder because you're trying to keep your unknowns, everyone through A&E, separate from your known negatives, which means that a lot of beds are sat empty that you can't use. I say a lot, we're talking about 99% of beds are always full. So that's been a real challenge. So days are very much about helping with beds, helping with discharges, really supporting the wards and the staff there. Also as site managers, a key part of our role is making sure things on the site are going okay. So, I was joking about fire, but we go to the fire emergencies during the day. Depending on the location, I'll go to medical emergencies, cardiac arrests. If they're on the ward, we're generally not needed, but we've had them in dialysis, in corridors, roles where you might need a little bit of operational support, we go to. Where the role comes into its own is on night shift. Croydon, we've got the hospital at night team. So it's led by myself and the medical registrar. So obviously the med reg is responsible clinically, I'm responsible operationally. So a key part of that is we act as what's called the bleep filter. So anybody who wants to get in touch with the doctors will come through us.
Wow. Well,
So
anyone for the whole hospital?
obviously maternity, pediatrics, surgical is slightly different. A lot of the time it's very useful because we can offer guidance and support to the nurses. That means that the doctors, rather than having say 50 bleeps an hour, can actually focus on what they need to do. They can deal with the sick patients. Challenging role that is, and then after that I think I had a fire call to A&E. Someone had set fire to a microwave member of staff.
Of course.
Didn't realise there was foil in their sandwich wrapper.
And that's why we give ourselves a really bad rap, don't we? We do all this amazing stuff in nursing, and then we set fire to the microwave.
So it's a very varied role, and it's one that I'm still learning, and it's the autonomy is something that I think I'd probably really have struggled with it if it wasn't for say a critical care background, where I was used to working with very senior doctors. I was used to being a key part of a decision-making process, or actually just making the decisions.
I think it's all learning how to have that communication, and learning as well that your opinion is as valid, if not more valid, than everyone else in the room. You're the one that knows the patient. And actually, I found when I first went to intensive care, I wouldn't really talk on the ward round that much. I might ask, oh, can this be prescribed, or can you change this? But I wasn't as vocal as then. I think a couple of weeks in, you're there before they even start the ward round, going hello, and you're presenting the issues. Learning those skills, I found, were really important and a really key part of critical care for me.
I think one of the things nurses forget that we offer is that we tend to stay in the same place a lot longer than doctors do, particularly the junior doctors. So we've recently had a change of registrars. It's their 6 months is up. They've moved around. They've been at different hospitals who have all dealt with COVID slightly differently, I think it's fair to say. And so you might be a gastro registrar by day, and then you come to do your first set of nights. So actually, it's been really helpful that I've been able to explain the COVID ALS process to the team, which, yes, you might know, but it's one of those things you need drummed into you day after day because it is different.
And as well, our normal resus situation, it's almost becomes embedded within you, doesn't it? It's an automatic process once
Yes.
you do an ALS, you've been in that situation lots of times. And when we've got the new thing, like, oh, now it's a COVID patient or it's an unknown patient, actually we need to then kind of embed that information again, don't we?
Telling people to not do CPR because they don't have PPE on is probably the weirdest experience I've had. Getting we got a cardiac arrest call that I went to, and the first bit of advice I could say was stop CPR. Like 5-6 months ago, you wouldn't have thought of it. What will you be telling people to do? That is very strange. It's surreal, but that is the age we live in now. This is the COVID era of nursing. It will, at some point, it will become less of an acute issue, more of a chronic issue. But for me, it certainly raises a question of, well, what about the next pandemic? What about the next emergencies? That sadly, this isn't it for healthcare. There will be other struggles.
And we've learned a lot, haven't we, as individual healthcare professionals and as an NHS and the private sector altogether. It's been a really steep learning curve.
Massively.
Have you got any advice for anyone that wants to move into being a clinical site practitioner?
I think having a background that fills you with confidence, that you've got to know, that you're good, so that you've got that confidence to say, no, this is what we're doing. This is what we're doing. And with that confidence, certainly for me, grown up in healthcare, become more mature, become more experienced, it's a lot easier to say, I don't know what I'm doing.
I think that's a really key thing, isn't it? It's almost like when you first qualify, you feel like, should I know it? If I admit that I don't know it, am I then looking like I'm incompetent or that I shouldn't be here? Where I was saying to I was teaching my students about pharmacology last week, and one of them was like, what, am I just supposed to know all of this? And I was like, well, you're obviously the basic principles, yes, and yes, you have to be safe to administer, but in terms of how to give the medication, no one's expecting you to be a library. They're not expecting you to be the BNF or Medusa. That's why we've got those systems in place for you to go and look it up. And I don't work clinically full time anymore. I go back and do my shifts in intensive care. There are medications I would give all the time without even thinking about before, and I would know the concentrations, the dose, how to give it, how to prepare it, the duration, where now I go and look it up. that's not a bad thing. In fact, I have to do that in order to be a competent practitioner and to be safe. We should all be looking up things every single time we do it.
Yes.
And by admitting that, and it's almost like you're just worried about almost someone going, oh God, she's got to go on that computer and see how to give comoxiclav. There's no issue with going on the computer and looking up how to give comoxiclav, because that means you're going to give it safely and correctly.
Totally to access that. And ultimately, whether you're a healthcare assistant or the chief nurse, it's about patient safety. That's the key question to ask yourself: is this patient safe?
I know this is quite early on because you've only recently started this new job in September. Where do you see your career going?
I think it's the sort of the double-edged sword of nursing, that you've got so many career options. It's very hard to actually plan a career.
That's true.
Now, I would have never thought I'd have gone to the private sector. I would have never thought I'd gone into site management. So, truth be told, I don't know.
Yeah, and it sounds like you've got a really good mix. And that actually,
Yes.
If you did want to go into more the operational side or the clinical side, actually you've got the best of both worlds, haven't you?
Totally. And I think there is no, for anyone new or anyone sort of having a little crisis of faith as to what do I do? And I fear there'll be a lot of nurses actually, now with having had an awful year in healthcare, concerned, what do I do for my future?
And it's one of the reasons why I actually started this podcast. How many options there are available in healthcare, that actually you can be a nurse and do operational control, you can be a prescriber, you can work in a GP clinic, you can be all over. I think we look at NHS jobs and you think, oh, I'm not qualified for that, or I can't do that, but actually you are, and you can be a nurse and do literally thousands of different jobs.
Have never met all the criteria that's essential on a job application. I think you'd be hard pushed to find a candidate who does. But if you don't apply, you definitely will not get a job.
Exactly. I think especially with the cuts to CPD funding, lots of jobs now might say, oh, you need to have a master's. But if units are never going to be able to fund a full master's, because it's either a year of years or part-time for 2 years, it's a lot of money. So units might say, oh, we'll pay for you to do the intensive care course, we'll pay for you to do an advanced assessment. So it's a 30 credit or a 15 credit module. It's very hard then for nurses to find the time, and they decide to self-fund.
A very exciting time to be a healthcare worker and a nurse. I think things are going to change rapidly. There will be a post-COVID change to the way hospitals run. So I think it's also, again, life happens. Be upset.
I think also we've got to allow ourselves to be upset. And
Yes,
actually, the amount of times I've gone in the linen cupboard and had a moment, and then someone's walked in to get a pillowcase, and I'm in there having a little cry. And that's okay. We're allowed to do that. We don't have to be super people. And we've got, I think, this view in nursing that we put on our scrubs and we put our uniform on, and therefore we have to be able to deal with everything all the time and not have breaks and not go to the toilet and not sit down and not eat anything because your patient's really unwell. And so I don't know any other job where you would go, oh, well, I worked 10 hours before I went and had a drink, or I went to the toilet, or I had a sandwich. That doesn't exist.
Yeah, it's ridiculous.
We stick up for our patients really well. We're amazing advocates. We need to advocate for ourselves, look after our own health. I think especially in the post-COVID era that hopefully we'll be entering soon, fingers crossed. That's something that I think nursing as a profession we can really take forward, that what we've learned, ironically, this was, the year of the nurse and midwife, wasn't it, in 2020?
Yes.
And I think the world almost took it as some bizarre challenge to see what can nurses and midwives take. The answer, unfortunately, is a lot. I think something we can all learn from this is to be kind and to look after ourselves as much as we do our patients.
Totally.
Definitely.
Totally.
And thank you so much, James. I feel like we've put the world to rights today.
Thank
you so much for being on the
very
podcast.
Enjoyable.
No, thank you very much. And good luck in your job, in your new role.
Thank you very much.